So I have the pleasure of introducing Dr. Aisha Sharik. Dr. Sharik graduated from Fatima Jinnah Medical College in Pakistan. She has a special interest in children's mental health. And she completed her fellowship here with us in the Child and Adolescent Psychiatry Program here at Texas Tech at El Paso, where she served as the role of Chief Fellow for the program. So she was my chief, okay? And she was a great chief. She's passionate about new and innovative treatments and has strong research interests. And she has published several papers in peer-reviewed scientific journals. So we're in the presence of greatness right now. Dr. Sharik is married to the love of her life and is the mother of 3 beautiful boys. Her future goals are to pursue her career as academic child psychiatrist, where she wants to study novel treatments for childhood onset mental illness. Welcome, Dr. Sharik.
Thank you so much. That's a very kind introduction, Dr. Ibanu.
It's true.
No, thank you so much. Joyce will guide us. So
yeah, so whenever you're ready. Yes, whenever you're ready, Dr. Sharik, let's go for it.
So welcome, everybody. Thank you so much for joining in. Like Dr. Ibanu said, I'm a child psychiatrist. I love mental health in children, adolescents. That's my passion. A little disclosure about CMA procedures. To claim CMA credit, participants must log on using their full name and, and remain logged on for the majority, if not the entirety of the CME activity. WebEx attendance logs with entry and exit stamps will be used to validate attendance requirements. Please note, if you are a call-in user, your name will not appear as an attendee. Therefore, we will not be able to verify your attendance for credit purposes. For credit, you must send an email to CME info. Here's the email with your full name, activity name, and date, and your call-in user number, so we can make a note of your attendance. Certificates for CME sessions are only available upon request. Participants may request a credit transcript by this email. Please include your full name, the title of the activity, and the date of the activity. Please allow at least 10 days after attending the session for the activity to reflect on your credit transcript. So the topic of my discussion is schizophrenia in children and adolescents. The objective of my talk is psychosis in children and adolescents is not commonly the predictor of diagnosis of schizophrenia. Psychosis in young population can be due to several reasons, including anxiety, substance use, physical, sexual, or emotional trauma, medical problems, as well as medication side effects. And it's really paramount for mental health providers working with children to rule out any other possible cause of psychosis before diagnosing a young person with schizophrenia. And that's true for pediatricians, family physicians. Everybody working with pediatric population has to be mindful that psychosis in children is not purely schizophrenia. And that will be the aim for my discussion today. Here's the diagnostic criteria for schizophrenia for your pleasure. The symptoms of schizophrenia include delusions, hallucinations, disorganized speech, disorganized or catatonic behavior, and negative symptoms. And 2 of these symptoms have to be present for at least 6 months to be diagnosed schizophrenia. If it's less than 6 months, if it's 1 month, it's schizophrenic form. If it's less than 1 month, brief psychotic disorder. There has to be a significant social and occupational dysfunction as well that impact 1 or more areas of functioning, including work, self-care, or interpersonal relationships. The continuous signs of disturbance should last more than 6 months, and they also can include prodromal or residual symptoms. And we'll talk about it later. This is a little colorful slide where I wanted to explain the symptoms in a little bit more detail. So the positive symptoms include delusions, hallucinations, disorganized speech, and catatonia. And they are usually linked to impairing social and work performance. Cognitive symptoms include attention, memory, executive function, and abstraction. Negative symptoms include affective flattening, alogia, avolition, anhedonia, and mood symptoms, of course, includes dysphoria, suicidality, helplessness, and negative symptoms and mood symptoms impair more of the occupational, interpersonal, and self-care aspects of a person's life. So the residual symptoms of schizophrenia include psychomotor slowing, underactivity, that can also be like no motivation. Patients will say, I don't want to get up in the morning. Flattening of emotions, passivity or lack of initiative, the same thing, a motivation kind of picture. Speech lacking in content or quantity, like poor speech. Nonverbal communication is also poor in these symptom categories. They have trouble with facial expressions. They can't recognize different emotions. Eye contact is poor. Voice modulation and posture is also impaired. Poor self-care and poor social performance are also included in the subset of residual symptoms. So the onset of symptoms for schizophrenia, they usually start in the mid to late 20s. It's really uncommon for children to be diagnosed with schizophrenia. Early onset of schizophrenia can sometimes occur before age 18, but it's kind of rare. Compared to that, very early onset schizophrenia in children younger than 13, that's extremely rare. And I made it bold just to emphasize less than 13. If there's a patient with psychosis, hallucinating, it's extremely rare. It can possibly happen, but it's very, very rare. The earliest indications of childhood schizophrenia, they can include developmental problems, such as language delays, late or unusual crawling, late walking, other abnormal motor behaviors, for example, rocking or arm flapping. So we also have to be mindful that if we are suspecting a patient with schizophrenia in the teenage years, we have to be mindful that there are some normal developmental behaviors that happen in teenage years. Just to be clear, there might be withdrawal from friends and family. They don't want to interact. They want to stay in their own little world. A drop in performance at school. They have trouble sleeping. Their schedules are all messed up. They're irritable or depressed. Just imagine a typical teenager. Lack of motivation is present, strange behavior, and substance use is really getting to start in those years. So we have to be mindful of all these factors in diagnosing our patients with psychosis. So in adolescents, schizophrenia diagnosis is they're more likely to have hallucinations, right? We sometimes think visual hallucinations. No, it's not schizophrenia, but in adolescent population, it can happen. They can have visual hallucinations more than the adult population. They are less likely to have delusions though. But as their symptoms revolve with the years and more typical signs and symptoms of disorder, they begin to appear. That includes like typical sign symptoms as per DSM, delusions, hallucinations, disorganized speech and behavior, and negative symptoms. So they can just be more defined later as they are a little bit older. I included this slide for us to remember the classic symptoms that we can experience in schizophrenia. Delusions is like the person is thinking he's a king or something, special power or something like that. That's what we mean by delusion. Disorganized speech, they're all over the place. Hallucinations, they're hearing things, they're seeing things. Grossly disorganized or catatonic behavior, they're not taking care of themselves. They're more like in their own world. The catatonia is extreme form of schizophrenia that can happen when the motor system gets involved. Negative symptoms, more along the lines of depression and immotivation. So before diagnosing psychosis with schizophrenia, we have to have certain diagnostic considerations in our mind. In adolescents, anxiety disorders are very commonly associated with hallucinations. I had a lot of kids in my own clinic who used to tell me, I hear voices all the time. I see shadows all the time. And treating their anxiety has helped their schizophrenia, their psychosis tremendously. It was not a predictor of schizophrenia. Autism spectrum disorder, intellectual disability disorder, these are, we always have to be mindful. These are brain structural anomalies. They have different behaviors. They have sometimes hallucinations. So we always have to be mindful for these disorders. Major depressive disorder, it can, when the mood is really depressed, psychosis can be one of the factors, and disorganization can be present too. Substance use, like I said, kicks off in teenage years. So we always have to be very mindful and very vigilant about screening for substance use in our teenagers. Bipolar disorder, it's rare, it's very rare, but the timing of onset is usually around 20, 21 years, a little bit earlier, like around 19 for some people, 18, 19. So just be mindful for that bipolar disorder, for increased energy and decreased need for sleep. Psychosis can be present for general medical neurological condition that I'll explain in a little bit. So these are the diagnostic considerations for psychosis, less commonly for child adolescent. Brief psychotic disorder, duration is less than 1 month, but more than 1 day. Schizophrenia disorder, duration more than 1 month, but it has to be less than 6 months. Schizoaffective disorder, mood symptoms are present independent of psychosis. And schizotypal personality disorder, there's a lifelong consistent and persistent pattern of personality. And for all the above 3, brief psychotic disorders, schizophrenia disorders, schizophrenia, the diagnosis is the same. We need 2 delusions out of the 5, but the timeline is different for all of them. That's the only difference. And I just wanted to mention patients with schizotypal personality disorder, they in the long run have an increased chance of developing schizophrenia, higher than any other personality disorder. So the routine workup includes working up for any comorbid condition. We usually like to get complete blood count, metabolic profile, thyroid profile, lipid panel, EKG, A1C, CT, MRI, imaging of the brain, and EEG to rule out seizures. So for the treatment, I like to emphasize, treat the diagnosis, not the symptoms, because psychosis is merely a symptom. If we establish the diagnosis, then we can gear our treatment towards the right direction. So for anxiety disorders, for example, the treatment of choice is SSRIs, SNRIs, CBT, and for specific phobias, exposure therapy. For autism spectrum disorder, antipsychotics have been studied, and Risperdal and Abilify are good choices. ABA therapy is extremely helpful for behavior problems. For major depressive disorder, SSRIs, different SSRIs, we can talk all day about which one is better than the other in what profile. SNRIs, CBT, ECT, substance use or withdrawal disorders, management of use and withdrawal symptomatically, and bipolar disorder, mood stabilizers, antipsychotics. Psychosis due to general medical or neurological condition, TBI, for example, symptomatic management, seizures, anti-seizure medications, delirium, treat the underlying cause. Haloperidol and risperidone has been studied and are a little bit better than other antipsychotics for delirium-related psychosis. So I just put it out there. I know this is a busy slide. I just want to make it a little bit simpler for you. First, so for the treatment of psychosis, there are antipsychotics. We know there are first generation antipsychotics and there are second generation antipsychotics. So the first generation antipsychotics, for example, haloperidol, chlorpromazine, they act on D2 receptor. They block the action of dopamine on D2 receptors. That's stronger than the second generation. The different receptors they block is mesolimbic, mesocortical, tuberoinfundibular, nigrostriatal, which causes extrapyramidal symptoms. This is for the sake of our own board review. We get a lot of questions on that. Mesolimbic pathway associated with positive symptoms, hallucinations and delusions. Mesocortical pathway more with the negative symptoms, cognitive symptoms, problems with attention, learning. Pertains to apathy, anhedonia, or decreased interest in social interactions. Tuberoinfundibular pathway leads to pituitary prolactin secretion, amenorrhea, galactorrhea, and nigrostriatal is extrapyramidal symptoms. Some of the side effects, there are other receptors that first generation antipsychotics act on: acetylcholine. They block acetylcholine, histamine, alpha-1 adrenergic receptors. Acetylcholine can cause some confusion, blurry vision, dry mouth, constipation. Histamine antagonism can cause weight gain, drowsiness, and alpha-1 adrenergic antagonist can cause orthostatic hypotension. The side effects for all the first generation antipsychotics, tardive dyskinesia, we always have to be mindful for tardive dyskinesia. These are abnormal, asymmetric movements of face, tongue, limbs that are caused by chronic dopamine blockade, and the incidence is 5%. That can be irreversible if it's bad enough, if it's not caught early enough. Drug-induced Parkinsonism, classic cogwheel rigidity, postural instability, resting tremor, bradykinesia, echinacea. Acute dystonia, muscular spasms of neck, eye, tongue, and jaw, and akathisia is like motor restlessness. I've seen patients, they tell me, I just want to walk. I just like to walk. They're pacing all the time. I actually have one patient with autism. He's on antipsychotics, and that's his main complaint, akathisia. So treatment of psychosis continued. Second generation antipsychotics, they can include olanzapine, risperidol, quetiapine, clozapine. There are long-acting ones, felperidone, etc. So they have lesser D2 blockade compared to type 1 first generation antipsychotics. They have a little bit of serotonin antagonism in addition that acts on mesolimbic pathway, dopamine blockade, serotonin blockade, results in the decrease of positive symptoms, decrease of delusions and hallucinations. Nigrostriatal pathway, again, dopamine blockade, and that can result in extrapyramidal symptoms. Tuberoinfundibular pathway results in hyperprolactinemia. Serotonin 2C are more prominent with clozapine, olanzapine, and seroquel quetiapine. They're more from mesocortical pathway, blocking dopamine and blocking serotonin and stimulating dopamine and norepinephrine release in the prefrontal cortex. They have a pro-cognitive and antidepressant action, so more helpful for negative symptoms and cognitive decline associated with the schizophrenia symptoms. Acetyl antagonism causes, acetylcholine blockage causes dry mouth, blurry vision, confusion, constipation, all those stuff. Alpha adrenergic antagonism, that can cause smooth muscle dilation, that can result in inability to maintain the blood pressure and orthostatic hypotension. Histamine antagonism, again, antihistamines make us drowsy, make us gain weight, increased appetite, obesity risk. Cardiometabolic effects, the mechanism is unknown. Fasting triglycerides and insulin resistance have been associated with type 2 diabetes, and that's a big monitoring factor. We like to monitor lipid profile once a year, at least for all the patients who are not high risk on second generation antipsychotics. If they're high risk, if there is any comorbidity, if they're a little bit older age, which doesn't apply to child adolescent, I like to get it every 6 months. So just to make sure their metabolic profile is okay. So in summary, psychosis in children and adolescents can be a manifestation of several mental health conditions. Schizophrenia is one of them and is a rare diagnosis in pediatric population, and other causes should be considered. I'll open the forum for questions or discussions. These are my family. This is my family. We like to hike outside. We go for hikes all the time. This is Grand Canyon. So if you have any questions, please feel free to ask Dr. Ibanu. She'll let me know.
All right. Thank you, Dr. Sharik. That was a very thorough discussion on schizophrenia and its treatment options. I haven't seen any questions yet. I do have a request for you to please share your slides via email. If possible, I have an email address on here and we can figure out, work that out with Joyce, right?
Yes, I already wrote it down. I got it.
Okay.
Thank you, Dr. Ibano.
All right, no problem. So please feel free to ask any questions that you have about this topic. If you have patients with schizophrenia, you've come across family members, anything you've ever wanted to know. Oh, good. Dr. Sharik, I don't know if you can see this question. The question is, what are some symptoms to identify in children or youth?
Yeah, I can see the question. So like I said, the symptoms are the same, but we have to consider the normal development. We always have to take that into consideration. The symptoms of schizophrenia, they're the same: delusions, hallucinations, disorganized speech or behavior, and negative symptoms. But we always have to take the developmental consideration, consider the age, consider the developmental level, the intellectual level, the family functioning. So everything has to be put together in order for us to make a diagnosis of schizophrenia. And I think I just wanted to make my message very clear. Schizophrenia is possible in adolescents, but we always have to keep our threshold very, very high for the diagnostic workup and the symptom screening in these children.
Okay. I don't know if you see the other question on there. Do you see it, Dr. Sharif?
I don't. Do you mind reading?
Okay, sure, I'll read it. It says, can you please repeat how often you need to check blood work for risperidone?
Yes, so for the metabolic profile, we like to get it at least once a year. But if there's any high-risk people, high-risk population, like for example, if there is an obese kid, there's a risk of metabolic syndrome already present, there's deranged profile, then we like to get it more often, every 6 months or even 3 months.
Okay. All right, so the Q&A is blowing up a little bit. So first question here is there a long-acting med that is cheap for patients that cannot be trusted with daily meds?
Long-acting medication?
Yes, that is cheap, can't be trusted with daily meds.
Not that I'm aware of. If there's something in particular, I know the Haldol is pretty cheap. That's something to consider. But there might be other options that I'm not aware of.
Okay. All right. Next question. Do you find that a lot of children are misdiagnosed with schizophrenia?
So I wouldn't say a lot, but there were a few patients that I had in my clinic They were diagnosed with schizophrenia at some point, but it was more like an anxiety issue they had. So I had a few of those instances where I had to change the diagnosis, but not a whole lot, not a whole lot.
So the next question is, can you differentiate a bit more between tardive dyskinesia and acute dystonia?
Sure. So tardive dyskinesia is abnormal motor movements. It usually involves mostly mouth. You will see like chewing movements, blinking movements, the hand wringing. But acute dystonia is more like muscle rigidity. It's more musculoskeletal. It's more like rigidity per se.
Another question, is prematurity a factor seen with children with schizophrenia?
I'm not aware of that literature. I might want to look it up. That's a great question. I'm not familiar with that, but thanks for bringing it up.
All right, people, any more questions? We have quite a bit of time, so, oh look, another one came in. Okay, so it says, I understand schizophrenia cannot be cured. What would be the life of children as adults?
So the schizophrenia is a very complicated diagnosis, and the treatment is quite complicated as well. Medication is only one part of the treatment. We can only do so much with the medication, but involving these children or adolescents or young adults in community programs, having an active case manager, having counseling, providing job support, occupational guidance, all these things, they have to be incorporated in order to have like a comprehensive treatment approach. Schizophrenia is not curable, but it's pretty manageable. People go by their life if they get into the right treatment and get the right services that they need.
Another question, can someone be diagnosed with schizophrenia in their 40s?
So that's the thing that I wanted to talk about. So the diagnosis, most of the mental, not just schizophrenia, most of the mental health diagnoses, they usually start in 20s, if not early 20s, late 20s. If there's a really late diagnosis, that it can happen. Primary psychiatric illnesses can also happen later in life. But more than likely, I would be more curious to find out if there's a substance use involved or if it's something more organic, more like a medical reason that these symptoms are present. Because it's not very common for schizophrenia or bipolar or all these disorders to start for the first time in later years of life.
Okay. So another question in the Q&A, what kind of anxiety disorders have you seen tend to also present with psychotic symptoms in children?
So yeah, that's a great question. Thanks for bringing it up. The kind of anxiety is, the most common anxiety disorders in children is generalized anxiety and specific phobias that start to develop around 5, 6, 7 years of age, depending on which phobia it is. There are specific timelines. But most common is some kids are scared because they can't sleep in the dark. I had a patient actually who was scared to sleep in the dark room, and he would start seeing different shadows, and he would freak out, and he would just have everybody in the room wake up. It was a mess. The entire house would wake up because he was scared of dark. He had a fear of sleeping in the dark. He was scared, and it's natural. I mean, they're just kids. So we just introduced different environmental changes, education, a lot of psychoeducation, and it improved. Of course, medication is also big part of anxiety treatment, but I would say phobias and generalized anxiety disorder are some of the most common ones that are encountered in our day-to-day practice as anxiety disorders in children.
Okay. Another question, can extensive stress and poor coping skills contribute to development of schizophrenia?
Yeah, so coping skills is important in any kind of, in any role, right? Poor coping skills leads to development of depressive symptoms, anxiety symptoms. I'm not sure of the exact literature if it does contribute to the schizophrenia or the aggravation of schizophrenia symptoms, but it just makes sense. The poor coping can also make the recovery difficult, if that makes sense.
Okay. Can children who've experienced severe trauma develop schizophrenia in later life?
That's a great question. I'm actually a big advocate for trauma. So trauma has its own set of symptoms. Trauma is a very complicated experience. The symptoms are very complicated. It can sometimes look like depression. Sometimes it can look like psychosis. Sometimes it can look like anxiety. Sometimes dissociations. So trauma in itself is a broad category. Trauma is I'm not aware, and I don't think there's any association of trauma in particular to schizophrenia. However, traumatic life experience might precipitate schizophrenia for the first time in anyone's life because it's a stressful experience. That's a fair possibility. But yeah, I don't know if trauma is directly linked to developing schizophrenia.
Okay. The questions are rolling in, Dr. Shari, in case you want to take a sip of water, because there's more.
No, I'm fine.
Okay. How do you try to differentiate cultural beliefs of seeing supernatural beings from psychosis? Did you get that?
Yeah, I'm just trying to understand the question.
Okay, so let me read it again. So the question says, how do you try to differentiate cultural beliefs of seeing supernatural beings from psychosis? So where in some cultures, it might be acceptable to see certain things.
Yeah, I think I would ask the parents. I would just talk to the parents about their cultural beliefs, what they think, and if everybody in the family believes in these supernatural things, that probably it's a cultural thing, right? It's not just like a kid with psychosis. But I think it's really important to talk to your patients and get to know them really well. And I know it doesn't happen overnight. It takes several sessions, several appointments. And the more you know them, the more you understand what's going on in their life. So spending time with their patients, getting to know them, exploring the options of treatment with them. So that's really important. These are important discussions to have with them.
Absolutely. And actually the person has expanded a little bit more on that question in terms of things like witchcraft and brujeria, is that how to pronounce it? Curandera. So, those kinds of beliefs. How do you separate that from psychosis, I guess?
Again, I would say it's the same thing. Believing if the grandma was doing witchcraft too, then sure, it runs in the family and it's a cultural, more like on the cultural norm side instead of labeling with the psychosis. So again, taking a broader history and keeping a broader approach to to getting to know the patient better.
Okay. What does controlled schizophrenia look like? Is there a length of time between crises?
So there's no set time. We don't have a clock to predict when it's going to happen, right? When the crisis is going to happen. But we can, we always go by functionality. In psychiatry, we go by functionality. What is the functional impairment? So we treat patients to be functionally able enough to hold their regular life responsibilities and activities and have a role in their life that is sufficient for them to be happy and where they are content. So our role is always determined. Our treatments are always determined by functionality. If the patient is functional in his own eyes, or if we are seeing the functionalities improving, we'll continue to titrate the treatment. And again, it's a combination of treatment, including the medication, including the therapy, including the active case management and community support. That all comes together. And the treatment is targeted at, it's individualized. Everybody gets their own treatment. Everybody, not a single, I cannot compare one patient with another. Every patient gets their own treatment, and the recovery is individualized too.
I wanted to add a little bit more to that, because Dr. Sharik is absolutely right. That is absolutely the answer. And in addition, this is something that was told to me early on by one of my attendings, we want to start treatment early. We want to decrease the frequency of acute episodes of psychosis. So decrease the compensation. The more episodes of psychosis you have, the less functionality the patient is likely to have in the future. So the main thing is early treatment, stay on treatment, try to find treatment that works as quickly as possible for as long as possible. Pretty much.
And that's a great point, Dr. Ibanu. Thanks for mentioning it. The early interventions, we actually had a big study here where we studied tons of kids with schizophrenia and bipolar. And we just wanted to establish early intervention is the way to go, because it's really important. I agree with you, absolutely.
Okay, another question. Actually, this is a couple. So the first one, how do you differentiate between an imaginary friend and a hallucination?
Yeah, that's a very tricky, slippery slope. That's a slippery slope. So hallucinations is more like sounds or images, right? Imaginary friend is more like in their own conscience. They have an imaginary friend, they interact with, they are friends with, they think about it. But hallucinations is more like active, like putting a headphone on your head and listening to a sound. And they experience that nonstop. It's quite stressful. Imaginary friends are usually not stressful. They're more like comforting for the adolescents. And imaginary friends also, there's an age for imaginary friends. It's more like towards the younger age groups, like 6, 7. I don't think it's that common in more than 13 or 14 years of age. So if there's a concern about imaginary friend, then I will call it more like a, I wouldn't say that's a hallucination. It would be more like along the lines of delusions or maybe ideas of reference, something like that. But I think age can differentiate and the content can differentiate.
I absolutely agree about the age one. And I just wanted to add, to put that in context, right? Just like Sharik said, if you have a 3-year-old with an imaginary friend, yeah, and there's nothing else going on. So remember, there are other symptoms of schizophrenia, right? So if it's just the imaginary friend, the 3-year-old, you don't have the other things. You don't have the disorganized behavior and all the other things that come with schizophrenia. You might want, you're thinking more towards imaginary friend, right? If you have a 15-year-old with an imaginary friend, now, are we looking at schizophrenia? You might want to consider things like IDD. So look at it in context and in terms of age, like Dr. Sharik said. Okay, more questions.
Thank you for elaborating on this, Dr. Banu.
Oh, yeah, because I feel like that question, I've had it before somewhere else as well. And like you said, it can be tricky. Okay, can schizophrenia be prevented?
I don't know. I don't know if there's any preventive strategies. People talk all about omega acids and healthy vitamins, diet and exercise, healthy lifestyle, but it's purely genetic. The incidence is pretty high in monozygotic twins, and the incidence is pretty high it's actually 50% in monozygotic twins. It goes down to 30% in dizygotic twins, but and 30% in children of parents who have schizophrenia as well. But it's your genetic makeup. Of course, environment plays a role in the development, and there are certain risk factors. Some people say if you're born in winter months, you have a higher chance of getting schizophrenia. So I'm not aware of any preventive strategies, but early intervention, like Dr. Iban was mentioning, is the key and the go-to for the treatment to have a better recovery process.
All right. We don't have any more questions at this time. And the other panelists can help me to see if oh, you know what? Another question just came in. Okay. Are there any developments to target the gene that is specific with schizophrenia to 8 times?
Yeah, that's a question beyond my educational level. I'm not a geneticist, but I would like to look it up. Thanks for mentioning. I appreciate the thought. There might be some gene targets, because I know it was back in time a few years ago, they were studying the genes that they can target that can help with the patients with schizophrenia. Dr. Ivan, are you familiar with anything like that?
No medication specifically targeting genes. I think just like you said, we're at the point of even mapping out, specific genes that are associated with schizophrenia. But in terms of like specific treatment for those genes, there isn't anything that we're aware of at this time. Okay, you have another? You sure you don't want that sip of water? There's another question.
No, I'm fine.
Okay, it's okay. Let me read it. Can schizophrenia be controlled without medication?
So without the medication, that's a tricky one. So I wouldn't say schizophrenia, because that's a pretty severe illness. It's actually the most debilitating illness of all the mental illnesses that we deal with on a daily basis. If it's a pure psychosis, then I would say, yeah, it might be because of some mood problems, some substance problems. Yeah, counseling will help. I would say more like psychosis might be treatable without the medication intervention, but if it's for sure schizophrenia, we're diagnosing with schizophrenia, then it's very hard to treat without the medication. And even with the medication, the compliance is an issue, the patient involvement, engagement, these are all struggles, because these patients are so sick, they don't have an insight into their illness. They're struggling, and they need a lot of support from their family, from community, from case managers. So that's a severe illness. I don't think it can be controlled without the medication.
What kind of inquiries did you have or encounters in your private practice? If you can tell us just a little bit about that.
Well, I think Dr. Sharik and Dr. Ibanu kind of harped on the major points. And one of the biggest things that we have to understand is the age group. When we're talking about schizophrenia, less than 18, early onset and very early onset of less than 13, and how rare they can be. And the point that they made was in regards to imaginary friends, the age group is around 3 to 5 years. And, beyond 5 years, you tend not to see that. And also imaginary friends are usually, the kids know they're imaginary, they're not real. And that's also something important. But I think they pretty much, hit the salient features and the salient points that one needs to identify when seeing kids with psychosis. As pediatricians, one of the biggest things that we suffer from is like when we see this, we kind of like struggle to find a psychiatrist immediately. Especially in the city, it's very hard to get a patient into psychiatry, and then our next option is to then send them to the ER immediately, where we're thinking, could there be something organic going on? Let's get a CT, get an MRI. And one of the things that CPAN does, and it's something that we all pediatricians and all family practitioners should have on speed dial, is it's a psychiatrist-led consultation service, and it is at no cost to all the primary care physicians. So all you do is pick up the phone, call Dr. Martin or Dr. De Vargas or one of the residents, and you get directed, and then you get appropriate information and what would we need to do in certain situations.
But just one little correction there, Dr. Mazum, you did excellent. The only thing is that the calls of consultations are just Dr. De Vargas and just Dr. Martin that are handling those calls. And we do have another question. Dr. Ibano, do you want to let
Yes.
Dr. Sharik know?
Sure. Okay, so the question is, bipolar and schizophrenia have similar symptoms. Why is it that the diagnosis can jump from schizophrenia to bipolar and back to schizophrenia for some clients, especially teens? Is it because of the fine line of diagnosing a child with schizophrenia?
In my mind, they are both very distinct diagnoses. Bipolar is increased goal-directed activity and decreased need for sleep for 5 days to a week. That is mania. Mania or hypomania. That's the hallmark that has to be present for a diagnosis of bipolar. However, it doesn't have to be present for schizophrenia. It might fall into the category of disorganized behavior, speech, all that stuff, but that's not the hallmark for a diagnosis of schizophrenia. However, the psychosis can be present in bipolar, cannot be present in bipolar. That's not a hallmark. Hallucinations, delusions, paranoia, perceptual ideas of reference, all these things, if they're present in bipolar, they wouldn't be the main theme of the presentation. For schizophrenia, that is the main theme. Hallucinations, delusions, disorganized behavior, disorganized speech, or if it's severe enough, the catatonia. So I would say schizophrenia patients are a little bit more sick and less functional. I'm not saying bipolar is not a very severe disease. Bipolar has its own cons, but it doesn't impair the functionality as much as a patient with schizophrenia would have. So the severity is quite severe in schizophrenia compared to bipolar.
Now, you do have another question. Actually, you have two more. What are some biological causes of schizophrenia?
So genetics is a big one. Heritability, like I was talking about, if the parents have schizophrenia, there's a 30% chance it will transmit into their children. That's one big one. Some people say if you're born, that might not be biologic, but environmental. If you're born in winter months, you have a higher likelihood of having schizophrenia. So these are the two big ones that I know on top of my head.
Another question, do you have any recommendations for teachers to identify red flags in children and youth?
Yeah, so like I was talking about, the same paying attention to the children's development and putting everything in the context of the development, it's very, very important. And putting it in the cultural context as well, that's very important consideration. And like Dr. Mazum was mentioning, we are here, CPAN, TChat, we are available for you. Call us if you have any questions, if you have any child, anytime. We have a direct line, Dr. DeVargas and Dr. Martin. They're both great. They have a lot of experience in working with children. So they'll guide you. They'll guide you.
The contact information is right there, right?
Yes, it is on, let's see, on the chat. Let me put it one more time.
Yeah.
So if anybody needs any consultations, any questions, medications, treatment options, definitely give us a call. They will answer it. And if you need any resources as well, you can talk to one of us, myself as a therapist. We can give you any referrals out here in the community so you can provide your patients with that too. Everybody, thank you so much for attending and hope you enjoyed it and learned a lot. I know I did. Thank you, Dr. Sherry. It was amazing.
You're welcome. Thank you so much for putting it together.
Thank you.
Bye
Yes,
for
thank
now.
you.
Thank you.
Yes,
Thank you,
bye
everybody.
for now.
Bye.